Will we start or wait for some more time?
Yeah, it's 9:30 and we can get started. Good morning to everyone. Welcome to another session of Pediatric CME. Today we have Dr. Shamik Shah, our consultant nephrologist and head of the nephrology department, AMH, who has kindly consented to talk about basics of electrolyte imbalance. We'll start with potassium. This imbalances hypo and hyperkalemia. Over to you, Dr. Shamik, and thank you very much.
Thank you, Dr. Brahmara, for your kind words and for the introduction. Good morning, everyone. I thought we'll go over some basic stuff about potassium, which is a very important electrolyte which we encounter in our day-to-day practice. And I thought we'll discuss briefly about hypo and hyperkalemia. So when we say disorders of potassium, of course, we know that the normal serum potassium level is between 3.5 and 5 milliequivalents per liter or millimoles per liter. Both have the values remain the same. But this is the potassium that we measure in the blood. What about the total body potassium in our? Let's briefly talk about that. So when we talk about total body potassium, we divide it into intracellular and extracellular. The intracellular potassium is the one which is inside the cells, of course, and the extracellular is divided into the intravascular space, so in the blood vessels and lymphatics, and the interstitial space, which is the space surrounding the tissues, I mean the cells and the blood vessels. Now, 98% of the total body potassium is inside the cell or intracellular, and only about 2% is extracellular, the one which we measure in our tests. So the total amount of potassium intracellularly is about 150 milliequivalents per liter, while the one which is outside the cells is about 4.5 milliequivalents per liter. So we know that there's a huge difference, and we know that potassium is positively charged, right? So there is an electrochemical gradient when we compare the intracellular to the extracellular potassium. And we talk about internal and external potassium balance. So the internal potassium balance, one of the main components is the sodium potassium pump, and which is actively generated by ATP, and the other ones are the potassium channels, which are in the lower part of the cell. So this electrochemical gradient that we talked about, it sets the resting membrane potential, which is needed for the contraction of smooth muscle, cardiac and skeletal muscles. Now, when we talk about external potassium balance, then we need to talk about how much of potassium is ingested versus how much is excreted. Now, in a normal diet, we ingest about 50 to 150 milliequivalents of potassium per liter. But we know that the extracellular potassium is only 4.5 milliequivalents per liter. That means the majority is excreted of what is ingested is excreted. And there are three mechanisms. The most important one, of course, is the kidneys, which excretes the extra potassium in the urine. And small components are also excreted in the feces, by the GI tract, and by sweat. So when we talk about hypokalemia, we say that there is too little of potassium in the blood. It could be because of an external shift or because of an internal shift. When we talk about external shift, there is increased potassium excretion, so there is a decrease in the blood. An internal balance shift means the potassium moves inside the cell, so the amount of potassium in the blood is reduced. Now, when we talk about internal balance shift, an important component is insulin. When we ingest a meal, glucose is ingested and insulin is secreted, right? The insulin acts on the cells to increase the glucose uptake and also increases the activity of the sodium potassium ATPase pump. So in people who have type 1 diabetes, this is a problem. They do not make insulin, and sometimes if insulin is given, more insulin is given from outside, or there is an increased dose, there is an increased activity of the sodium potassium pump, which pulls all the potassium inside the cell. Another internal balance shift is alkalosis. When the blood is alkaline, that means the hydrogen ion concentration in the blood is high. So there is a high pH, right? Now, how does the body react to this alkalosis? It generates these hydrogen ions from the cell to go out into the blood, and in exchange, potassium from the blood enters inside the cell. So this is a potassium hydrogen exchanger. So the alkalosis is taken care of by increasing the concentration of hydrogen ions in the blood, but at the same time, the potassium level goes down because a lot of potassium has moved intracellularly. However, do remember that this does not happen with respiratory alkalosis, because in respiratory alkalosis, there is an increased amount of carbon dioxide, but that is lipid soluble and it moves freely across the cell membrane. So there is no hypokalemia. Hypokalemia only occurs in metabolic alkalosis. Now, we also know that certain catecholamines affect the potassium balance. There are beta-2 adrenergic receptors and alpha adrenergic receptors on the cells. When beta-2 adrenergic receptors are stimulated, it stimulates the sodium-potassium pump, and that means potassium moves in and sodium moves out. And when there is alpha adrenergic stimulation, it causes the calcium-dependent channels to get activated, and which pushes calcium out. So when we talk about beta adrenergic agonist and alpha adrenergic antagonist, then the use of these causes hypokalemia. Now, when we talk about the external balance shift, there is a difference in the balance between the intake and the output. So in certain cases, there is a low intake in patients with anorexia, prolonged fasting, or special kind of diet which people tend to follow. But the main problem with hypokalemia in the external balance shift involves the excretion through the kidneys. And let us talk about that. So this is the functional unit of the kidney, which is a nephron, right? Every person has 2 million nephrons, 1 million in each kidney. Potassium is freely filtered at the glomerulus, and about 2/3 is reabsorbed at the proximal convoluted tubule. Around 20% is reabsorbed in the thick ascending limb of the loop of Henle. The remaining 30% is taken care of by the distal convoluted tubule and the collecting ducts. Here, both secretion and excretion take place through two types of cells. So we know these two types of cells. One is the alpha intercalated cells, and the other type of cells are called the principal cells. So if we zoom in and look at these cells, we will see how this works. In most of the cases, excretion is the one which is the predominant mechanism, because extra potassium needs to be excreted out of the kidney. So if we blow up, look at a principal cell, then aldosterone is one of the hormones which acts on the principal cells, and it opens the sodium and potassium channels on the luminal side. On the basolateral side, we can see the sodium-potassium ATPase pump, which is again stimulated by the aldosterone. So what happens is, from the luminal side, sodium is taken up inside the principal cells, and then it exits and goes inside the blood through the sodium-potassium ATPase pump. So obviously, potassium from the blood enters inside the principal cells, and once the concentration of the potassium increases in the principal cells, then these potassium channels which are open on the luminal side, potassium leaves through them and gets excreted in urine. So whenever there is a problem in the aldosterone, for example, primary hyperaldosteronism, then more potassium is excreted and less potassium is retained, causing hypokalemia. This can also happen in compensated heart failure and cirrhosis of liver, which is secondary hypoaldosteronism. Diuretics also cause hypokalemia, and how do they cause that? The loop diuretics and thiazide diuretics inhibit the upstream sodium reabsorption in the loop of Henle. So more sodium is delivered to the distal tubule downstream, right? When there is more sodium in the distal tubule, again, this sodium, because of the concentration gradient, moves inside the principal cells, stimulates the sodium-potassium ATPase pump, and so more potassium moves from the blood into the principal cells and is excreted in the urine. Also, more water is being shifted downstream because of the diuretic effect. So there is a relatively low potassium concentration in the luminal side. Again, low potassium in the luminal side causes more potassium to be excreted through the principal cells. So this is basically how diuretics cause hypokalemia. Now, when we talk about external balance shift, there may be loss through gastrointestinal secretion, either through vomiting or diarrhea. When we talk about vomiting, the amount of potassium lost in vomiting is not very high, so direct losses are minimal, but a lot of hydrogen ion is lost because the stomach acid is lost. So it causes metabolic alkalosis, and as we have seen, how metabolic alkalosis causes hypokalemia. Diarrhea, on the other hand, there is more direct loss of potassium through diarrhea, and this can be from infections, from inflammatory bowel disease, or laxative abuse. So both these conditions cause hypokalemia. Also, a very small amount of potassium is lost in sweat, especially if the person is doing vigorous exercise in the hot ambient temperature. So these are the causes of the potassium loss or hypokalemia. Now, we said that the resting membrane potential is very important when there is a gradient between the potassium inside and potassium outside, which allows the cell to depolarize and causes the activity of the skeletal, smooth, and cardiac muscle. Now, in hypokalemia, when all this potassium goes inside, the resting membrane potential goes down. So when the resting membrane potential goes down, these muscle cells become less reactive to stimuli. So there is diminished contraction of smooth muscles, which cause constipation, skeletal muscle weakness, cramps, and flaccid paralysis are seen. And cardiac muscles respiratory muscles are also affected, causing respiratory depression. And of course, cardiac muscles are also affected, causing arrhythmias and sometimes cardiac arrest. So now, when we say hypokalemia, we say that the potassium is very little or less than 3.5 milliequivalents per liter in the blood. Causes, as we already saw, are reduced potassium intake, abuse of laxatives, vomiting, metabolic alkalosis, diuretics like loop and thiazide diuretics, right? So what are the symptoms? Patients are often asymptomatic, or they may complain of palpitations. They may have smooth muscle weakness, which causes ileus, which results in nausea and vomiting. And in severe cases, there are muscle weakness in the skeletal muscles and can cause diaphragmatic paralysis and difficulty in breathing. Now, when potassium is less than 3.5 milliequivalents per liter, an EKG or ECG should be done as soon as possible. However, the ECG changes don't correlate with the severity and progression of hypokalemia, so we have to be careful. In hypokalemia, we may see ST segment depression, depressed T wave, and increased amplitude of U wave, which is seen in the lateral leads V4 to V6. And sometimes the T wave and U wave there is a T and U wave combination. When potassium is below 3.5 milliequivalent per liter, the QRS complex gets prolonged, the T waves are more inverted, and there is more ST segment depression. Causes, as we already discussed, diarrhea, vomiting, and diuretic uses. But if that is not the cause, then we have to look at urinary potassium to see if hypokalemia is caused by renal losses. Ideally, this should be done by 24-hour urine potassium, but in an emergency situation, that is not possible. So we do a spot urine to potassium to creatinine ratio. This gives us an idea of what. So the next step will be to do an ABG in such cases. If the patient has metabolic acidosis, meaning the pH is less than 7.35 and bicarb level is below 22 milliequivalents per liter, then we look at the spot urine potassium and creatinine ratio. If the creatinine potassium ratio is low, then the cause is GI, maybe laxative abuse. If the urine potassium to creatinine ratio is high, then we are looking at diabetic ketoacidosis or type 1 or 2 renal tubular acidosis, which is the cause of the hypokalemia. Now, if the patient has metabolic alkalosis, where pH is more than 7.45 and bicarb is more than 27 milliequivalents per liter, Then we look at the urine potassium and creatinine ratio and see if it is low, then the cause of the hypokalemia is mainly, or most likely, vomiting. If it is high, the urine potassium to creatinine ratio, but the patient is normotensive, then the patient probably has used diuretics or is abusing diuretics, or the patient may be suffering from Bartter or Gitelman syndrome. If the patient is hypertensive in metabolic alkalosis, then the patient is probably suffering from primary hyperaldosteronism or a renovascular disease like renal artery stenosis. So basically, if the urine potassium to creatinine ratio is less than 40 milliequivalents per gram of creatinine, the kidney is responsible. Kidneys can't retain enough potassium. But if it is below 13 milliequivalents per gram of creatinine, then the kidney is not responsible. Something else is causing the hypokalemia, maybe GI loss or something else. Now, we also need to look at the serum magnesium levels when we are evaluating a patient with hypokalemia. When there is magnesium deficiency, the potassium secretion increases in the distal tubule. So if magnesium is below 1.5 milliequivalents per liter, then we need to supplement the magnesium by oral or IV magnesium sulfate. If potassium is between 3 and 3.4 milliequivalents per liter, we say that the patient is having mild to moderate hypokalemia. If the patient has vomiting and metabolic alkalosis, we treat the patient with oral potassium chloride. If the patient has laxative abuse and has metabolic acidosis, then we use oral potassium bicarbonate. Both of these can be given at the rate of 10 to 20 milliequivalents 2 to 4 times per day. If there is a renal cause, then we might need to use oral potassium with a potassium sparing diuretic like amiloride or spironolactone. And if the patient cannot tolerate oral potassium, IV KCl may be used for emergency situation. Of course, if the patient is dehydrated, we have to use IV isotonic saline. Now, if potassium is below 3 milliequivalents per liter, or the patient is symptomatic and has ECG changes, the treatment should be given right away, right? And how do we do that? We start IV KCl at 10 to 20 milliequivalents per hour. Rates more than 20 milliequivalents per hour are highly irritating so cannot be given in peripheral veins because it causes pain and phlebitis. But in a life-threatening situation, we can give up to 40 milliequivalents per liter. Serum potassium is checked every 2 hours to see how much the potassium is corrected. If of course the patient is dehydrated, we have to give IV isotonic saline as well with the KCl which we are giving to the patient. Now let's talk about primary hyperaldosteronism. It is because of an aldosterone producing adrenal adenoma, right? The diagnosis is the patient is usually hypertensive. There is high serum aldosterone level, low serum potassium, and decreased plasma renin activity. If we do a CT scan of the abdomen, we can see adenomas which are less than usually 4 centimeters in size, but regular in shape and borders. And CT attenuation is seen with less than 10 house per units. So this is a treatment is either a laparoscopic adrenalectomy, and if there is a secondary hyperaldosteronism, which we know by Bartter and Gitelman syndrome, then this is a genetic condition which causes excessive sodium chloride loss in the urine. So sodium chloride is not reabsorbed in the loop of Henle, in Bartter syndrome, and in the collecting duct in Gitelman syndrome. So when there is a loss of volume, this activates the renin-angiotensin-aldosterone system, which causes hyperreninemia, which causes hyperaldosteronism. And we have seen that there is an increased potassium and hydrogen secretion in the kidneys, which causes hypokalemia and metabolic alkalosis. In Gitelman syndrome, there is excessive magnesium loss in the urine. And acute hypokalemia or metabolic alkalosis, if it is present, we have to treat it. In Bartter syndrome, there is polyuria, growth delays, and cognitive disability as well. In Gitelman syndrome, the symptoms are usually polyuria, muscle cramps, and fatigue. Patients can have hypotension as well. How do we diagnose Between Bartter and Gittelman, we have to look at urinary chloride. But in both cases, urinary chloride is more than 25 milligrams per liter. Genetic testing, of course, is helpful, but it might not be immediately available. In that case, we look at urinary calcium excretion. If urinary calcium is normal or high, then the patient is suffering from a Bartter syndrome. But in Gittelman syndrome, the urinary calcium will be low. Treatment of this condition is lifelong, but relies on potassium-sparing diuretics and supplementation with potassium chloride and magnesium.
What is a subset? Subset is part of a set. Superset is a collection, a huge collection, like we can say universal.
Just give me a second, Dr. Shamik, 1 minute.
Superset will be having all the elements which are present in subset.
Can I request you to unmute yourself and continue? Thank you.
Okay, can you hear me now?
Yes, Dr. Shah.
Yeah, so we talk about hypokalemic periodic paralysis, which is another cause of hypokalemia. Let me just go back to that. So in hypokalemic periodic paralysis, this is a genetic disorder which is manifested in late childhood or adolescence. Symptoms are usually episodes of generalized muscle weakness, which affect respiratory muscles, and it is triggered by vigorous exercise or stress or a high carbohydrate meal. And this lasts for a few weeks. Potassium, if we check, it is generally around 2.4 milligrams per liter. Treatment during the episode, of course, is same to what we discussed, oral KCl. And between episodes, we tried to give them carbonic anhydrase inhibitors like diazepam. So this was about hypokalemia. Now, let us talk a little bit about hyperkalemia. So hyperkalemia, we say when there is a higher level of potassium in. So again, we'll talk about the internal and external balance shifts, right? So in internal balance shift, when there is insulin deficiency, especially is seen in children who have type 1 diabetes. So we know that insulin is required for the glucose uptake in the cells and for the activity of the sodium potassium ATPase pump. But when there is type 1 diabetes, the patient does not produce insulin, so glucose uptake is affected. There is a decreased activity of the sodium potassium ATPase pump, so more potassium remains outside in the blood, which causes hyperkalemia. Another important cause is metabolic acidosis, when the blood is too much acidic or where there is increased hydrogen ion in the blood. So obviously there is a low pH, and the body tries to maintain the balance by activating the potassium hydrogen exchanger. So hydrogen ions go inside the cell in exchange for potassium ions which move outside the cell. So ultimately the acidosis gets corrected because the hydrogen ion moves inside the cell, but as a consequence, a lot of potassium ions leave the intracellular space and come out into the extracellular space, including the blood, which causes hyperkalemia. Of course, this is not seen in respiratory acidosis because the carbon dioxide in respiratory acidosis is lipid soluble and carbon dioxide moves freely across the cell membrane. So there is no hyperkalemia which is seen in respiratory acidosis. Even in organic acids like lactic acidosis or ketoacidosis, these acids also move freely across the cell membrane. So we do not see hyperkalemia in these conditions. Now, again, about the catecholamine of effect, which we saw earlier for hypokalemia, there is activity of the beta adrenergic receptors and the alpha adrenergic receptors. And we know that when there is a stimulation of the beta adrenergic receptors, there is a stimulation of sodium potassium pump, and the alpha adrenergic receptors, when they are stimulated, stimulate the calcium dependent potassium channels. So when the patient is on a beta adrenergic antagonist or a beta blocker, we may find hyperkalemia. Or when the patient is on an alpha adrenergic agonist, we may find patient is having hyperkalemia. Another important internal balance shift is hyperosmolarity, when there is increased osmolarity in the extracellular compartment. So water moves from inside the cell outside into the interstitium. This causes the shrinkage of the cells, and therefore the potassium concentration in the cell rises. When the potassium concentration rises, to balance it out, more potassium leaves the cell and goes into the extracellular compartment. So this causes hyperkalemia. Another important aspect of hyperkalemia or cause of hyperkalemia is cell lysis. When there is we know that a lot of potassium is inside the cell. So when the cells break down, all of this potassium moves out into the extracellular space. This is seen commonly in burns, rhabdomyolysis, and in tumor lysis syndrome. So all of these conditions, we are likely to find a lot of hyperkalemia. Another internal balance shift is seen when a lot of exercise is being done, especially in a hot climate. The cell works harder and uses up all the ATP. So the potassium channels which are in the cells, they open up because of the loss of ATP, and potassium moves outside into the extracellular compartment. This is not usually very severe, and the shift is usually small. But if the patient has CKD or patient is using beta blockers, then this hyperkalemia can be significant. Now, when we talk about the external balance shift, this is again a balance between intake and output. So we know that we take about 50 to 150 milliequivalents of potassium per day. Mostly, if the kidney is normal, it takes care of the excretion. But if there is a rapid excessive intake, for example, intravenous fluids, like ringer lactate, for example, then this can cause iatrogenic hyperkalemia. Other than that, the problems which happen are because of problems. So patient suffering from acute kidney injury or chronic kidney disease. In such conditions, the kidney is not able to excrete the potassium well, and because of the deficiency in excretion of potassium by the kidney in the face of a higher intake, we may see that the patient is developing hyperkalemia. So we say hyperkalemia when there is too much potassium in the blood, which is more than 5 milliequivalents per liter. As we said, the common causes are metabolic acidosis, hyperglycemic, hyperosmolar state, medication like potassium-sparing diuretics, or tissue breakdown, crush injuries, rhabdomyolysis, or tumor lysis, and of course, acute or chronic kidney disease. Of course, when there is a high potassium intake. What are the symptoms? Patients sometimes are often asymptomatic, or they may complain of palpitation, paresthesias, or muscle weakness. This flaccid paralysis usually starts in the lower limbs and goes up. When there is severe hyperkalemia, this can affect the renal function as well. So patient may become oliguric when the daily urine output drops below 400 mL. When the potassium is more than 5 milliequivalents per liter, we should first do an EKG. If the EKG is normal, patient is asymptomatic and no apparent cause is seen, then the patient probably has pseudo hyperkalemia. Now, what happens? We know that during or after the blood draw, potassium can move outside into the cells, especially if the patient is actively clenching and unclenching their fist. Then the muscle activity causes the potassium level to rise, and this can rise up to 2 milliequivalents per liter in that particular arm. So also during blood draw, the cells, red blood cells, can lyse and cause release of potassium. If the patient has thrombocytosis or leukocytosis, as for example in chronic leukemia, CLL, then these lymphocytes are frail, which break down and cause the potassium to go outside in the circulation. So in such cases, we just repeat the serum potassium level, but at the same time, look at the CBC to see if the patient has pseudo hyperkalemia or not. Again, like hypokalemia, EKG changes don't really correlate with the severity and progression of hyperkalemia. If the potassium is between 6 and 7 milliequivalents per liter, we are likely to find a tall and peaked T wave. This is usually seen in the precordial leads V1 to V3. If potassium is between 7 and 8 milliequivalents per liter, then in addition to the peak T wave, we will see a prolonged PR interval and a depressed SD segment. And if the potassium is above 8 milliequivalents per liter, then we will see again a taller T wave, a more prolonged QRS, and a flat P wave. In the last stages, we will see the sinusoidal pattern, and patient can die of ventricular fibrillation. But cardiac changes don't always align with the level of potassium in the blood, so we do need to remember this. And ventricular fibrillation can happen anytime, even if the changes are not very apparent. So when we are faced with hyperkalemia, we must order a basic metabolic panel, look at the BUN, creatinine, bicarb, glucose level, and also look at the serum potassium, sodium, calcium, and chloride level. Now, if the patient has renal impairment, then the BUN and creatinine levels are elevated. We calculate an estimated GFR based on the patient's creatinine, age, gender, and weight. When the GFR is between 60 and 90, we said that the patient has mild impairment. When the GFR is between 30 and 60, we say that the patient has moderate impairment. And when the GFR is below 30 ml per minute, so CKD stage 4 or 5, this is severe impairment. In a hyperglycemic, hyperosmolar state, sometimes glucose levels can be as high as 800 milligrams per deciliter. Now, if the patient's sodium is below 135 milligrams per liter and the calcium is below 8.5 milligrams per deciliter, the cardiac effects of the hyperkalemia are precipitated. Of course, we do need to look at bicarb level. And if we see that the bicarb level is below 22, we must do an ABG as well. And we confirm that by looking at the pH, which is below 7.35, and of course the bicarb will be less than 22 milliequivalents per liter. In most of the, to look at the, we calculate the anion gap to find the cause. And when a patient has diabetic ketoacidosis, then usually the sugar levels are above 350 milligrams per deciliter. What are the symptoms? So when patient is symptomatic, or when there are EKG changes, or the potassium is more than 6.5 milligrams, treatment is urgent and is life-saving. Or in a patient whose potassium is between 5.5 and 6.4, but the patient has renal impairment and ongoing tissue breakdown. In both of these scenarios, the treatment should be immediate. So whenever we are giving the treatment, of course, it goes without saying that serum potassium needs to be monitored every 2 hours. We start with IV calcium gluconate, give 10 ml of 10% calcium gluconate over 3 minutes, and we repeat this every 30 to 60 minutes if hyperkalemia persists. Rapid-acting therapies are used to move potassium back into the cells. However, do remember that this does not remove the total body potassium, but it stabilizes the cardiac myocytes if the potassium moves back inside the cells. So how do we do this? By giving 10 to 20 units of insulin in 500 ml of 10% dextrose over 1 hour. The effect begins within 20 minutes and can last for up to 6 hours. When we give this, potassium reduces by 0.5 to 1.5 milliequivalents per liter. Of course, blood glucose needs to be measured also every 6 hours because we are giving 10% dextrose to the patient. In addition to this, we can give beta-2 adrenergic agonists like nebulized albuterol to again move potassium inside the cells. If the patient has metabolic acidosis, we have seen this, right? The hydrogen ion moves inside the cell and potassium moves outside the cell, causing hyperkalemia. So, to counter this effect, the hyperkalemia associated with metabolic acidosis with pH less than 7.1, we give IV sodium bicarbonate to the patient. This helps again in mitigating the effect of hyperkalemia. If the patient has no renal impairment, then loop diuretics can be given, because we saw already before how loop diuretics cause hypokalemia. So, but if the patient is euvolemic or hypovolemic, then we need to give loop diuretics along with isotonic saline. Now, if the patient has impaired kidney function, then loop diuretic dose needs to be adjusted. Probably they need higher doses. And we might or might not need to give isotonic saline. We have to be very careful. Another method to remove potassium from the body is by using gastrointestinal cation exchanges like potaromer. This exchanges the potassium with calcium and can be given orally or enema. If potaromer is not available, K-oxalate is available in our hospital. We can use this. This is an exchange resin with which uses sodium or calcium and exchanges it with potassium. If, however, the patient is severely renally impaired, we need to do hemodialysis. If dialysis cannot be done within 6 hours, again, we use the cation exchanger till dialysis becomes available. Now, if potassium is between 5.5 and 6.4 milliequivalents per liter, and the patient has no symptoms, no EKG changes, but severe renal impairment, then again we need to reduce the potassium in 12 hours by using dialysis. If dialysis is not available, till that time we can use the gastric cation exchanger. If potassium is between 5 and 5.4 milliequivalents per liter, patient is asymptomatic and there are no ECG changes, then we can just reduce the potassium through dietary modification. So we ask the patient to avoid foods which are rich in potassium, like banana, orange, watermelon, brinjals, peas, and sweet potatoes. So these are the foods which are rich in potassium, which we ask the patient not to take. If the same patient is hypertensive or hypervolemic, then in addition to this, we can give loop diuretics. If potassium still remains high, then we can use the gastric cation exchange resin until an underlying cause is identified. Now, what are the causes of hyperkalemia? Of course, acute kidney injury and chronic kidney disease. And if a patient has acute kidney injury, what will we see? That the patient is usually oliguric, is volume overloaded, may or may not have uremia, and may have metabolic acidosis. If, of course, the patient has chronic kidney disease, then patient may be anuric, and we may find uremic symptoms in advanced stages. So treatment of underlying conditions depends on the stage of the kidney disease. Another important cause is diabetic ketoacidosis or hyperglycemic hyperosmolar state, where insulin deficiency causes hyperglycemia and hyperosmolarity, right? So the water from the cells moves outside and causes shrinkage of the cellular volume. So potassium also moves from the cell outside into the cell. And in this condition, there is not enough insulin to stimulate the sodium-potassium pump. So again, more and more potassium moves outside the cell. Patients are dehydrated, they may complain of nausea and vomiting, and there may be mental status changes. We know all this. And but do remember that because of the more urine, their total body potassium is also low. Treatment is, of course, plenty of fluids and give insulin supplementation to the patient and reverse the acidosis. Once the acidosis is reversed and potassium goes below 3.5 milliequivalents per liter, we may need to give IV KCl2 and then switch the patient to long-acting insulins like glargine or detemir. Some medications can also cause hyperkalemia. So chief among them is a potassium-sparing diuretic like spironolactone. So these medications, they induce the mineralocorticoid or aldosterone resistance. So either they compete, spironolactone competes with aldosterone, or some of the other medications like amiloride block the sodium channels in the collecting tubule. These medications induce hyperreninemic hypoaldosteronism, and the blocking of the renin, angiotensin, aldosterone at different levels like ACE inhibitors and ARBs can also cause hyperkalemia. When there is an induced hyporeninemic hypoaldosteronism, other medications that we can think of are NSAIDs and calcineurin inhibitors like cyclosporin and tacrolimus. Beta blockers can also cause hyperkalemia when they interfere with the beta-2 adrenergic activity, which we have seen earlier. This is relevant when patient is having renal impairment because the excess potassium is not excreted properly. Treatment, of course, is to stop the offending medication, and if hyperkalemia is persistent, we treat it accordingly. Ongoing tissue breakdown like rhabdomyolysis or tumor lysis syndrome. Patients in rhabdomyolysis, the patient complains of muscle pain and dark urine. Blood test reveals increased level of creatinine kinase. Urine shows myoglobinuria. And treatment, of course, is hydration with isotonic saline and sodium bicarbonate. In patients receiving radiation or cytotoxic therapy for leukemia and lymphoma, we do need to look out for tumor lysis syndrome. In addition to hyperkalemia, these patients have hyperuricemia, hyperphosphatemia, and hypocalcemia. Another important cause of hyperkalemia is Addison's disease, where the patient is unable to make sufficient cortisol and aldosterone. There is a reduced aldosterone level, which causes renin secretion and causes hypereninemic hypoaldosteronism. There are two conditions, acute and chronic. Acute, we know, is known as adrenal crisis also. There is catastrophic symptoms, hypotension, shock, vomiting, abdominal pain, fever, and mental status changes. Chronic Addison's disease, usually fatigue, weight loss, abdominal pain, muscle joint pains, etc. Diagnosis is reduced serum ACTH, reduced serum cortisol, reduced aldosterone, and increased renin in the blood. Treatment is usually by giving fluorocortisone, daily dose of 50 to 100 micrograms. Important another cause is iatrogenic hyperkalemia. Usually when we give too much to treat hypokalemia, and the pendulum swings the other way. Another important cause is mannitol, which is given for brain injury. Mannitol causes brain hyperosmolarity, and again, we saw this how hyperosmolarity causes hyperkalemia. Particularly, we have to, if the patient has renal impairment, we have to be very careful. And another important cause is hyperkalemic periodic paralysis, which is a genetic disorder where the sodium channels remain open for a longer time. So a lot of sodium enters the cell, and therefore a lot of potassium has to move out of the cells to maintain the equilibrium or balance. In this case, symptoms, brief episodes of muscle weakness and paralysis, which is precipitated by triggers of cold, exercise, fasting, and ingestion of excessive potassium. Potassium is normal or slightly elevated, but during an acute episode, we can do an EMG or genetic testing and to see elaborate diagnosis of hyperkalemic periodic paralysis. Treatment is usually not necessary because the episode is short lasting, but we of course have to prevent the triggers. I think that is all that I wanted to share with you. If there are any questions, I am happy to answer them.
Thank you so very much, Dr. Shamik, for that exhaustive coverage of hypokalemia and hyperkalemia. If there are any questions anybody has. So we in pediatrics often encounter hypokalemia rather than hyper. Hyper, of course, when we deal with type 1 diabetics. But yeah, hypokalemia is most often seen, especially with gastroenteritis.
Yeah.
But you as a nephrologist would be seeing this on a daily basis, I think, with most of your patients.
Yes.
It will either be hypo or hyperkalemia.
Yeah, so we do see a lot of hyperkalemia, especially in our chronic dialysis patients. So a point that I wanted to make is we regularly see potassiums above 6.7, 6.87. in our chronic dialysis patients. Mostly this is because of a lack of dietary control. But the point that I wanted to make is even though their potassium levels are above 6.8, 7 sometimes, we don't see any ECG changes in these people. Most likely because of the chronic state and the chronic process, their bodies get used to the higher levels of potassium.
Thank you, Dr. Shah. Presentation.
Yes, go ahead. Go ahead, Dr. Vanita.
You can ask, Doctor. I'll join. You were asking something.
Yeah, very often cardiac arrhythmias are cited as a cause when you're correcting potassium as IV, and the need for monitoring with a cardiac monitor. So do you have, in your experience, I know theoretically we need to connect a monitor, but then sometimes practically, given our situation here, we are in shortage of cardiac monitors. So in your experience, what is the level where you really need a cardiac monitor as against, you go ahead with IV potassium correction without the monitor? Do you have any guidelines for this from your practical experience?
Practically, I would say if potassium, you mean when you are correcting hyperkalemia or hypokalemia?
I think hypokalemia is more, of course, for both of them, you require a cardiac monitor.
Yeah.
But since we deal with, the question is for both hypo and hypokalemia.
Yeah, so in case patient has hypokalemia and you are treating with IV KCL, probably the correction would not be too fast if you are not giving more than 20 milliequivalents per hour. So in that case, probably just doing an hourly or 2 hourly potassium, you might get away with without the cardiac monitor. But I think when we are treating hyperkalemia, especially when potassium is above 6.5, sometimes even the glucose insulin drip and all these things that we give are still not effective in lowering the potassium. So in that case, I think hyperkalemia, a cardiac monitor is definitely required because we need to see if the changes are mitigated on the monitor or not. If not, we need to again give more and more treatment for the hyperkalemia.
Thank you, Doctor. Dr. Vanita, please go ahead.
Thank you, Dr. Shamik. That was a nice presentation. We have calculators for pediatric. I'm saying for the audience with pediatrics, I'll have to reiterate, we have an inbuilt calculator to calculate doses and such. Adult, it's an easy thing, but for us, all works per kg. So the safety limits and cutoffs are all dependent on the per kg and the concentration of what we use as the infusion, although it resembles the same physiology as what you said, the irritation to the peripheral circulation when we count on the central circulation. So I think for pediatric perspective, it would be useful if you can appraise yourself about the dosings. Dr. Shamik did mention the doses in adult. So the same question Dr. Brahmer was asking, anything amounts to quicker correction. We have a way of slow correction when asymptomatic, but then anything amounts to quicker correction, which would be 0.3 to 0.5 ml per kg. It definitely requires monitoring. And of course, an additional magnesium correction, because most of these resistant cases requires magnesium correction. And another thing, doctor, RTAs are a major chunk of pediatric potassium disorders, and then we ourselves do not really encounter it as a simple obvious diagnosis. It always masquerades, and we always encounter it in ICU settings if we don't pick it up. Like most of these ventilator dependent, and then it's very difficult to wean. And they do present as cases which are shock, and then the acidosis is not really commensurate with the explainable causes and things like that. And again, the correction and all depends on the type of RTA, and RTAs are genetic incidences, and our population in Bahrain also is got predisposition. And again, most of them have been diagnosed in PICU by genetic testing, and that is something we all have to be aware of. And again, that forms a major chunk of our difficult hypokalemias, especially distal RTAs. Apart from that, Dr. KXL8, when we were preparing guidelines, we did look into it. We don't have it, is what I understand.
No, we do. We do.
This is oral, doctor, or rectal?
It can be used for both, and it is the only issue is that it is available as a, I think, 300-gram container or something like that. It's a huge dose. So we want to use it for a short period of time. The patient still needs to buy the entire container. That is the only problem.
Okay, it's as a resin. We can use it.
Yeah, it's a powder.
And yeah. Okay, yeah. But I don't see it available in our medication listing. Maybe they will fetch it when we ask for it, I think.
I think it is available.
Because, when we were making guidelines, I did check upon, and we didn't have it. And right now I'm checking. I'm not seeing it in the listing. So again, the dose would be again 1 gram per kg. That's how we decide. 1 gram per kg divided doses.
Yeah, ours is easy. We give 30 grams. So.
Yeah, we go for 1 gram per kg in divided doses, and until the target resolution, we use the resin.
Right.
Yeah, I'm not finding.
It is. So, doctor, the name is Resical. If you see, yeah.
Okay.
Resical powder, 95.3% weight by weight. But as I said, it is available as a 300-gram container.
Okay.
The other thing that I wanted to touch upon was that for the renal tubular acidosis.
Sorry, Resical is 300.
300 grams, yeah. It is calcium polystyrene sulfonate.
Okay.
KXL8 is sodium polystyrene sulfonate. Both are same. Yeah.
Similar. Okay, doctor.
Thank you. Yeah, for this one, for
so
renal tubular acidosis.
What's the dose you use as adults?
For adults, we use 30 gram stat, and then we can repeat it two more times.
Okay.
Or 30 gram TDS or something like that. But we do need to remember that these can cause gut necrosis. So we have to be careful using this.
Okay.
You have to use them sparingly. Some people, they said we'll not reduce the oral intake, but we will continue using this. I tell them this is not a good idea.
It's a good
you cannot use this chronically.
Okay. And which is better, oral or rectal?
Oral works well.
Quicker resolution?
Probably rectal might be quicker.
Okay.
Yeah.
Sorry, doctor, you were saying something added to this.
Yeah. So for the potassium replacement in renal tubular acidosis, potassium bicarbonate, unfortunately, is not available with us. And these patients require massive doses, large doses.
So we are using potassium citrate version, doctor. So this is available as Urolite U, and we are going for that. And that particularly to avoid nephrocalcinosis, we need that version.
Yeah.
And just bringing up the level of correction, we add the potassium chloride. Otherwise, potassium chloride is really not the first choice. Yeah.
Yeah. So, but potassium bicarbonate is available in Salmonia and BDF, I think. So, if your patient needs, you can give a prescription and they can buy it from there.
We go for citrate, potassium citrate. So,
Yeah.
okay.
So this is as an oral formulation, right? The potassium
Yeah,
bicarbonate
tablets.
that you're talking about?
Tablets. Yeah, tablets. Yeah.
Tablets. Yeah.
Potassium citrate and potassium bicarbonate, I think both are available as tablets.
Yeah. Thank you very much, Dr. Shamik, for your time and your efforts in
My pleasure.
exhaustively covering these two topics. We hope to have you on board to cover other topics to complete the basics of nephrology.
Sure.
So that will strengthen our knowledge base and help in dealing with patients in the most effective manner. Thank you very much. Thank you.
My pleasure,
And no more questions. We'll close the meeting.
Thank you.
Thank you, sir.